It's great to be here today as a follow-up to the incredible heart failure symposium that we conducted at the first annual Women's Cardiometabolic Health Masterclass that was held in Los Angeles. And I'm here with two of our panelists. I'm Pam Taub. I'm a cardiologist and professor of medicine at UC San Diego, and I'll let the panelists introduce themselves. Dr. Greenberg.
Hi, I'm Barry Greenberg, and I am a distinguished professor of medicine and chief of the heart failure treatment program at the University of California in San Diego. And it's nice to be back with you and Anu to talk about some of the issues that we brought up at that meeting, which was so inspirational to me.
I'm Lala. I am a heart failure cardiologist at Mount Sinai in New York. I'm just so thrilled to be back here with you guys because it's taking me back to Los Angeles and really to a meeting that changed my perception of what a meeting can mean for us as clinicians and as professionals and as individuals. So thank you so much for inviting me and looking forward to our conversation.
Great. Well, let's start with Dr. Greenberg, who is really one of the pioneers in the field of heart failure. And during your career, Barry, you've seen the evolution of heart failure treatments. And I want to get your perspective on what has been the most exciting developments.
So great question, Pam. And when I started in heart failure, the management parameters that we had, the drugs that were available were really limited. We were using DIG and diuretics and a lot of prayer for our patients. And I think we have a lot more to offer now. And this is much of this is based on recognition that neurohormonal activation plays a central role in the pathogenesis of heart failure, so that the use of neurohormonal blocking agents, starting with the development of ACE inhibitors and ARBs, later going on to beta blockers and MRAs, and now coming full circle with combined neurohormonal modulating agents. And by that, I mean specifically the combination of sacubitril valsartan, have all had a major impact on the treatment of patients with heart failure. The other aspect of care that I am really excited about now is the finding that many of the classes of drugs that we use extend across the spectrum of heart failure, regardless of left ventricular ejection fraction, so that we now have drugs for patients with mildly reduced and preserved ejection fraction. And perhaps we can talk a little bit more about them in a moment.
As a field, how do you think our understanding of heart failure with preserved ejection fraction has evolved?
I think it is evolving. I don't think we quite understand it yet. We continue to lump this as a homogeneous group. And I think we as clinicians recognize it's anything but. There are a variety of different pathophysiologies involved. And if I were to predict what will happen over the next 30 years, I think that phenotyping of these patients into different categories and greater personalization of therapies is probably the way that we're going to go. But we're a lot better than we were when we started, when we considered HFpEF, the small stiff heart syndrome. It's much more than that. There's a lot going on there, and I think a lot of potential targets for us.
And I think we used to say the small stiff hearts of, especially women.
Exactly.
Yeah. Well, Anu, let's talk about the future. What are some upcoming therapies that you're excited about?
Yeah, thanks so much, Pam. And I really also what you said, Barry, really resonated with me, which is that we're seeing things along the spectrum now. And so I think this very much plays into how we can anticipate things may change in the future, is that we were previously, I think, used to putting things in buckets, right? This is HFrEF, this is HF mildly reduced EF or intermediate previously PEF. Then there's prevention on one end and then heart failure on the other end. And many of you know this, I like calling it heart function. Again, not just to be cutesy and not only for the potential psychological benefits that that might carry for the patient and for the provider or the clinician, but also because it emphasizes that it's all a spectrum. And so what I'm really excited about is that we're now seeing things, and we saw this especially at this conference, in that heart failure is a part of prevention and prevention is a part of heart failure, and it's all just one circle. And I think with some of these new drugs that are coming out, like tirzepatide, these GLP-1 agonists for weight loss, other things that are really driving home the importance of early prevention are going to have an impact on heart failure. And vice versa, I think in heart failure, previously we thought, okay, this is too late, you're at the end stage, you're at the end of the spectrum. It doesn't mean that we cannot think about preventative therapies then too. So I think what I'm looking forward to is appreciating one's cardiovascular health across one's lifespan, starting in early childhood and then going into the elder years, and recognizing that it's all a part of one continuum. I think that's what really excites me. The other thing I would just say really briefly is that I am incredibly invigorated by the tremendous advancements we've made in guideline-directed medical therapy and the incredible results that they offer to our patients in terms of improving quality of life and quantity of life. But I also think that there's emerging interest in combination therapies with devices. So it's not that we just need to think devices on one end, medical therapy on the other, but rather how can they be synergistic and how can we individualize care for one particular patient? So I think the future is very exciting for all of cardiology.
I like how you talked about how prevention and heart function are coming together. And I think what we're doing is breaking down the traditional silos. So you mentioned tirzepatide. I use GLP-1 receptor agonists all the time in my practice, and I find that I'm treating atrial fibrillation, sleep apnea, heart failure with potentiating that weight loss. And so everything is finally starting to come together, and we're realizing there's so much organ crosstalk. And in order to be effective clinicians, we have to appreciate all the different organs, including the kidney. So that it's really nice to see that come together. So let's end by talking about what's bugging you lately. What do you want to see changed in the field? Let's start with Barry.
Oh, I think there's one big gorilla in the room here, and that is data that's available about implementation of therapies. You know, it's a bit frustrating to me as a clinical trialist, as I'm sure it is to you, Pam, and you, Anu, that we have all of these medications and different therapies available. And we know that when they're implemented properly, we can get a substantial improvement in the clinical course of our patients. Yet when we look at data from some of the registries about implementation, we find that many of these therapies are underutilized. So, and they're underutilized in ways that various different segments of the population are particularly not seeing these therapies. And to me, I think one of the major challenges over the next decade is to improve implementation of therapies, particularly in minority groups, in women, and even across the board. They're not being used in any group to the extent that they should be.
Yeah, I mean, I wish I had something unique to offer besides what Barry said, but that really is the thorn, right? Because there's so much excitement about all of the new developments, SGLT2 inhibitors on the medical therapy end, in terms of the prevention therapies we've already talked about. Device-based therapies are advancing as well, but who has access to these treatments? And so I think it really highlights a great degree of structural racism. I think there is it's uncomfortable sometimes to talk about, but needs to be addressed and called out, because we are seeing the direct impact of differential access to these therapies. And I think it's incumbent upon us to take some of these resources that we're putting into new development and steer it into how can we actualize the uptake of these therapies for the patients who need it most. So I think very much so, I would hope that that is where we are moving to spend more of our energy and our efforts, so that we can have an equal playing field.
I'll tell you what's bugging me about, in general, the field. I'd like to see more lifestyle strategies used, such as cardiac rehabilitation. There's such an underutilization of cardiac rehabilitation. So I would like to see that utilized more, because lifestyle is so synergistic with pharmacologic and device therapy. So let's not forget about that. Well, I want to thank both of you for participating in our live symposium, and I'm looking forward to seeing you both back at the conference. And thanks for your time today.